The fluorescent lights hummed their usual monotonous tune as Sarah Mitchell walked through the corridors of Mary's hospital at 6 in the morning. Her white sneakers squeaked against the freshly mopped floors, a sound she had grown so accustomed to that she barely noticed it anymore. The smell of antiseptic mixed with the faint aroma of coffee from the nurse's station greeted her like an old friend. She had been working these halls for almost 8 years now, and every corner, every room, every crack in the ceiling tiles had become as familiar to her as the lines on her own palms. Sarah was 32 years old, with dark brown hair that she always kept tied back in a practical ponytail, and warm hazel eyes that seemed to notice everything. She wasn't the kind of person who stood out in a crowd. She didn't wear flashy jewelry or expensive clothes. Her scrubs were the standard hospital issue, pale blue with tiny white flowers, and her only accessories were a simple watch her grandmother had given her, and a stethoscope that hung around her neck like a badge of honor. To most people who passed her in the hallways, she was just another nurse, one of dozens who worked tirelessly behind the scenes to keep the hospital running smoothly. But Sarah had never minded being invisible. In fact, she preferred it that way. Being invisible meant she could do her job without interference, without people constantly looking over her shoulder or questioning her decisions. She had learned early in her career that the best nurses were often the ones nobody noticed, until something went terribly wrong or miraculously right. She took pride in her work, in the small victories that nobody else saw, like the elderly patient who finally smiled after weeks of pain, or the frightened child who stopped crying when she held their hand during a difficult procedure. The emergency department was already buzzing with activity when Sarah clocked in. The night shift nurses looked exhausted, their faces pale under the harsh overhead lights as they hurriedly finished their charting before heading home. Sarah exchanged brief greetings with a few of them, asking about how the night had been. The usual chaos, they told her. A car accident victim, 2 heart attacks, 1 suspected stroke, and an endless stream of minor injuries and illnesses that kept them running all night long. Dr. James was already at the central desk, reviewing patient files on the computer screen. He was a tall man in his mid-40s with graying hair and wire-rimmed glasses that constantly slipped down his nose. He had been the head of the emergency department for 6 years and had a reputation for being brilliant but demanding. He expected excellence from everyone who worked under him, and he had little patience for mistakes or incompetence. Sarah had worked with him countless times over the years, and had earned his respect through her skill and dedication, though he rarely showed it openly. Sarah grabbed her assignment sheet for the day and scanned through the list of patients. Room 4 needed vital signs checked every hour. Room 7 was a young man with a possible appendicitis waiting for surgical consult. Room 9 was occupied by an elderly woman with pneumonia who needed breathing treatments. Room 12 had a teenager who had broken his arm skateboarding and was waiting for orthopedics to set the fracture. It was a typical morning in the emergency department. Nothing out of the ordinary, nothing that suggested this day would be any different from the thousands of days that had come before it. She started her rounds methodically, moving from room to room with practiced efficiency. She checked temperatures, blood pressures, heart rates, and oxygen levels. She administered medications, adjusted IV drips, and reassured worried family members that their loved ones were receiving the best possible care. She documented everything meticulously in the computer system, knowing that proper documentation could make the difference between life and death in critical situations. Every nurse knew that if it wasn't documented, it didn't happen, at least not in the eyes of the law. Around 9 in the morning, Sarah took a quick break to grab a cup of coffee from the nurse's lounge. The room was small and cramped, with an ancient refrigerator that hummed loudly in the corner and a microwave that had seen better days. A few chairs were scattered around a scratched table covered with outdated medical journals and half-eaten boxes of that someone had brought in to celebrate a birthday or anniversary. Sarah poured herself a cup of coffee from the pot that had probably been sitting there since 5 in the morning and added 2 sugars and a splash of cream. She sat down for just a moment, allowing herself to close her eyes and take a deep breath. These quiet moments were rare in the emergency department, and she had learned to treasure them whenever they came. But even as she tried to relax, her mind was still running through her mental checklist of tasks that needed to be completed before her shift ended. She needed to follow up on the lab results for the patient in room 4. She needed to make sure the surgical consult for room 7 happened before noon. She needed to check if the orthopedic resident had been called for the teenager in room 12. Her moment of peace was interrupted by the sound of sirens approaching the hospital. Sarah immediately stood up, abandoning her coffee cup on the table. Sirens meant incoming trauma, and incoming trauma meant all hands on deck. She quickly made her way back to the emergency department, where other nurses and doctors were already gathering near the ambulance bay doors. The paramedics burst through the doors moments later, pushing a stretcher at full speed. On the stretcher was a middle-aged man, probably in his early 50s, with pale gray skin and sweat pouring down his face. His eyes were closed, and his breathing was labored and irregular. One of the paramedics was performing chest compressions as they moved, while the other rattled off vital signs and medical history to Doctor, who had appeared seemingly out of nowhere to take charge of the situation. Massive heart attack, the paramedic shouted over the noise and commotion. Found him collapsed at his office. No pulse when we arrived. We've been doing CPR for about 12 minutes. Given 2 doses of epinephrine, still no response. They wheeled the patient into Trauma Bay 1, and suddenly the room exploded into controlled chaos. Nurses and doctors surrounded the stretcher, each person knowing exactly what their role was without being told. Someone was cutting away the patient's shirt and business suit. Someone else was attaching electrodes for the cardiac monitor. Another person was establishing better IV access. Doctor stood at the head of the bed, directing the resuscitation effort like a conductor leading an orchestra. Sarah immediately fell into her role. She grabbed the crash cart and positioned it next to the bed, making sure all the emergency medications and equipment were readily available. She drew up doses of various drugs that Doctor might need, holding them ready in case he called for them. Her hands moved with practiced precision, never fumbling, never hesitating. She had been through this scenario hundreds of times before, though each time still made her heart race with adrenaline. The monitor showed a heart rhythm that was barely compatible with life. Ventricular fibrillation, the chaotic electrical activity that meant the heart was quivering uselessly instead of pumping blood to the brain and vital organs. Doctor called for the defibrillator, and everyone stepped back from the bed as the electrical charge was delivered to the patient's chest. His body jerked violently, but when they checked the monitor, the rhythm was unchanged. They continued CPR. Someone else took over chest compressions, their arms pumping up and down in a steady rhythm that Sarah could count in her sleep. 1 and 2 and 3 and 4 and 5. Push hard, push fast, don't stop. Another dose of epinephrine. Another shock from the defibrillator, still no change. The minutes ticked by, each one feeling like an eternity. Sarah glanced at the clock on the wall. They had been working on this patient for almost 20 minutes now. She knew what that meant. The chances of a successful resuscitation decreased dramatically with every passing minute. After 20 minutes of CPR without response, the likelihood of brain damage, even if they did get his heart started again, was extremely high. She had seen Doctor call off resuscitation efforts before when they reached this point. It was one of the hardest decisions a doctor had to make, knowing when to stop fighting and accept that death had won. But Doctor wasn't giving up yet. He called for another round of medications, another shock. Sarah handed him the medications he requested without being asked, anticipating his needs before he voiced them. This was the kind of teamwork that developed over years of working together, a silent communication that required no words. She could read the tension in his shoulders, see the determination in his eyes as he refused to let this patient die without exhausting every possible option. The family had arrived by this point. Sarah could hear them in the hallway outside the trauma bay, their voices rising in panic and fear as someone tried to explain what was happening. She felt a pang of sympathy for them. They had probably left home that morning expecting an ordinary day, never imagining that their husband, their father, their loved one would collapse at work and end up fighting for his life in an emergency room. Life had a cruel way of changing in an instant, she had learned. One moment everything was normal, and the next moment your entire world was falling apart. 25 minutes. The compressions continued, mechanical and relentless. Sarah could see the exhaustion on the face of the nurse who was doing them now, the third person to take over the task. It was physically demanding work, and it was impossible to maintain the proper depth and rate of compressions for more than a few minutes at a time. But they kept rotating, kept pushing, kept fighting even as hope began to fade from the room like air leaking from a balloon. Doctor's jaw was set in a hard line. Sarah recognized that expression. He was beginning to consider calling the code, declaring the resuscitation unsuccessful, and allowing the patient to die with whatever dignity remained. She had seen him wrestle with this decision before, seen the weight of it settle on his shoulders like a physical burden. Being a doctor meant having the power to save lives, but it also meant having the responsibility to know when saving was no longer possible. Sarah's mind was racing even as her hands continued to work automatically. She reviewed everything they had done, searching for anything they might have missed, any intervention they hadn't tried. They had given all the standard medications. They had shocked the heart multiple times. They had checked and rechecked the airway to make sure oxygen was getting to the lungs. They had that the IV lines were working properly. They had done everything by the book, everything that medical science said should be done in this situation. But something was nagging at her, a small voice in the back of her mind that wouldn't be quiet. She looked at the patient's face again, really looked at it, studying the color of his skin and the shape of his features. There was something not quite right, something that didn't fit the pattern of a typical heart attack victim. His color was wrong, not the pale gray of someone whose heart wasn't pumping blood, but a slightly different shade that she couldn't quite identify. She glanced at the monitor again, watching the chaotic rhythm of ventricular fibrillation dance across the screen. Then she looked at his neck, noticing for the first time a slight of the jugular veins that hadn't been visible when he first arrived. Her brain started connecting dots, forming a pattern that made her stomach clench with sudden realization. Without thinking about protocol or hierarchy, or the fact that she was just a nurse and not a doctor, Sarah spoke up. Her voice cut through the noise of the resuscitation with unexpected clarity and force. "Stop compressions for a second," she said, her tone brooking no argument. Everyone in the room turned to look at her in surprise. It was highly unusual for a nurse to interrupt a code like this, especially when the physician in charge hadn't asked for input. Doctor's eyes locked onto hers, and she saw a flash of irritation cross his face. "What is it, Sarah?" he asked, his voice tight with tension and barely controlled frustration. Sarah stepped closer to the bed, her eyes never leaving the patient's neck. "Look at his jugular veins," she said. "They're distended, and his color is off. Not typical for an MI. I think we might be dealing with cardiac tamponade." The room went silent for a moment as everyone processed what she had said. Cardiac tamponade was a life-threatening condition where fluid accumulated in the sac around the heart, preventing it from beating effectively. It could be caused by trauma, by infection, by cancer, or by other underlying conditions. And it could absolutely cause cardiac arrest that wouldn't respond to standard resuscitation efforts, because the problem wasn't with the heart's electrical system, but with physical compression preventing the heart from functioning. Doctor moved to the bedside and examined the patient's neck himself. Sarah held her breath, wondering if she had overstepped, if she had seen something that wasn't really there. But after a moment, Doctor's expression changed from irritation to intense focus. "Get me an ultrasound machine," he ordered, "now." Someone ran to grab the portable ultrasound. Sarah felt her heart pounding in her chest as she waited. If she was right, they might still have a chance to save this man. If she was wrong, she had just wasted precious seconds of resuscitation time and would probably face consequences for interrupting the attending physician during a code. The ultrasound machine arrived, and Doctor quickly positioned the probe on the patient's chest. The screen flickered to life, showing grainy black and white images of the heart. Sarah leaned in slightly, trying to see what the screen was showing. She wasn't trained in reading ultrasounds, but she had seen enough of them over the years to recognize basic anatomy. "There," Doctor said, pointing at the screen. "Large pericardial effusion with signs of tamponade. Sarah, you were right." The room erupted into motion again, but this time with a different purpose. Instead of continuing the standard resuscitation protocol, they were now preparing for an emergency, a procedure where a needle would be inserted into the sac around the heart to drain the fluid that was compressing it. It was a delicate and dangerous procedure, especially during a cardiac arrest, but it was the only chance this patient had. Doctor's hands were steady as he prepped the patient's chest and positioned the needle. Sarah handed him each piece of equipment he needed, her movements precise and efficient. The room was quieter now, everyone holding their breath as they watched Doctor guide the needle under ultrasound visualization toward the fluid-filled sac around the heart. When the needle penetrated the pericardium, dark red fluid began flowing out into the syringe. Doctor aspirated slowly, carefully, removing the fluid that had been preventing the heart from beating effectively. Sarah watched the cardiac monitor, hoping to see some change in the rhythm. At first, nothing happened. The chaotic ventricular fibrillation continued unchanged. But then, as more fluid was removed, something remarkable occurred. The rhythm on the monitor began to change, organizing itself into something more regular. Not a normal rhythm yet, but definitely responding to the intervention. Resume compressions, doctor ordered. Give another dose of epinephrine. They continued the resuscitation, but now with renewed hope. As more fluid was drained from around the heart, the cardiac rhythm continued to improve. After another shock from the defibrillator, the monitor suddenly showed a normal sinus rhythm. A collective gasp went up from everyone in the room. "We have a pulse," one of the nurses announced, her fingers pressed against the patient's carotid artery. "It's weak, but it's there." The patient's color began to change almost immediately, the deathly pallor giving way to a healthier pink as blood once again flowed to his tissues and organs. His chest began to rise and fall more regularly as his own respiratory drive started to return. Within minutes, his eyes flickered open, confused and disoriented but undeniably alive. Sarah felt her legs go weak with relief. She had to steady herself against the crash cart to keep from stumbling. Around her, the other staff members were celebrating quietly, exchanging relieved smiles and congratulatory shoulder pats. They had snatched this man back from the edge of death, had given him a second chance at life that he wouldn't have had if they had given up just a few minutes earlier. Doctor turned to look at Sarah, and for the first time in all the years she had worked with him, she saw genuine admiration in his eyes. "That was excellent clinical observation, Sarah," he said. "You just saved this man's life." Sarah felt her cheeks flush with a mixture of pride and embarrassment. She wasn't used to being singled out for praise, wasn't comfortable with being the center of attention. "We all saved him," she said quietly. "I just noticed something that didn't fit the pattern." But everyone in that room knew the truth. If Sarah hadn't spoken up when she did, if she hadn't trusted her instincts, and had the courage to interrupt the attending physician during a code, this patient would have died. Her observation had changed everything in those critical 13 minutes between when she first noticed something was wrong and when doctor successfully drained the fluid from around the patient's heart. The patient was quickly transferred to the intensive care unit for continued monitoring and treatment. As the trauma bay emptied out and the staff dispersed to their other duties, Sarah found herself standing alone in the now quiet room. The floor was littered with torn packaging from medical supplies, discarded gloves, and drops of blood. The crash cart needed to be restocked. The stretcher needed to be cleaned and prepared for the next emergency. She began the cleanup mechanically, her hands working while her mind was still processing what had just happened. She had been a nurse for 8 years, and in that time she had participated in countless resuscitations. Some had been successful, many had not. But this one felt different. This one had required her to step outside her usual role, to trust her judgment over protocol, to risk looking foolish or insubordinate in order to advocate for what she believed the patient needed. As she wiped down the stretcher, Sarah thought about all the times she had bitten her tongue during her career, all the times she had noticed something but didn't speak up because she didn't want to question a doctor's authority or because she was afraid of being wrong. How many patients might have benefited if she had been braver sooner? How many other nurses were out there right now, hesitating to voice their concerns because they were just nurses and not doctors? The emergency department had returned to its usual controlled chaos by the time Sarah finished cleaning the trauma bay. New patients were arriving, old patients were being discharged, and the cycle continued as it always did. But something had shifted, not just in the department, but inside Sarah herself. She had proven to herself, and the news of what happened in Trauma Bay 1 spread through the hospital faster than Sarah could have imagined. By lunchtime, nurses from other departments were stopping her in the hallways to congratulate her. The intensive care unit called down to thank her for saving their new patient, who was already showing remarkable signs of recovery. Even the hospital administrator, a stern woman named who rarely left her office on the 4th floor, sent an email commending Sarah for her clinical excellence and quick thinking. Sarah didn't know how to handle the attention. She had spent her entire nursing career deliberately staying in the background, doing her job well but never seeking recognition or praise. Now suddenly everyone seemed to know her name, and people were looking at her differently. Some with admiration, some with curiosity, and a few, she noticed, with what looked like resentment or jealousy. Not everyone was happy when someone else received recognition, even if that recognition was well-deserved. During her lunch break, Sarah retreated to a quiet corner of the hospital cafeteria with a sandwich she had no appetite for. She picked at the bread absently while replaying the morning's events in her mind. What if she had been wrong? What if she had spoken up and embarrassed herself in front of everyone? What if her interruption had caused a delay that cost the patient his life instead of saving it? The weight of what could have gone wrong pressed down on her shoulders like a heavy blanket. Her phone buzzed with a text message from her best friend Rachel, who worked as a pediatric nurse on the third floor. The message simply said, "Heard what you did this morning, you absolute hero. When are you going to realize you're a amazing question mark, question mark, question mark?" Sarah smiled despite herself. Rachel had been trying to boost her confidence for years, always insisting that Sarah was too modest and didn't give herself enough credit for her skills and accomplishments. Before Sarah could respond, Doctor appeared at her table carrying a tray with what looked like a chef's salad and a bottle of water. He gestured to the empty chair across from her. "Mind if I join you?" he asked, though he was already setting his tray down before she could answer. "Of course not," Sarah said, straightening up in her seat and putting her phone away. She felt suddenly nervous being alone with the head of the emergency department outside of a clinical setting. Their interactions were usually brief and always professional, focused on patient care rather than personal conversation. Doctor sat down and began arranging his silverware with precise movements that somehow matched his methodical approach to medicine. He was quiet for a moment, and Sarah wasn't sure if she was supposed to say something or wait for him to speak first. Finally, he looked up and met her eyes with an intensity that made her uncomfortable. "I've been thinking about what happened this morning," he said. "That was the kind of clinical assessment I expect from experienced physicians, not floor nurses. No offense intended." Sarah felt a flash of irritation at the phrase "floor nurses," as if her position somehow made her inherently less capable of critical thinking than doctors. But she kept her expression neutral and simply nodded. "I just noticed something that didn't fit," she said. "Anyone could have seen it." "But they didn't," Doctor said firmly. "I didn't. None of the residents or other attendings who were in that room saw it. You did. And more importantly, you had the courage to speak up even though it meant interrupting me during a code, which I know isn't easy given the hierarchy in hospitals." Sarah didn't know what to say to that, so she just took a sip of her water and waited for him to continue. "I checked on our patient in the ICU before coming down here," Doctor went on. "He's doing remarkably well. Intact, breathing on his own, talking to his family. The cardiologist thinks he'll make a full recovery. Without your intervention, he would have died on that table. Do you understand the significance of that?" "I'm just glad he's okay," Sarah said quietly. Doctor leaned back in his chair and studied her with an expression she couldn't quite read. "How long have you been working in the emergency department?" he asked. "Almost 8 years," Sarah replied. "I started right after I graduated from nursing school." "And in those 8 years, how many times have you noticed something that other people missed?" Sarah considered the question. "More than once," she admitted. "But usually I mention it to the charge nurse or quietly suggest something to the resident rather than speaking up in front of everyone." "Why?" Doctor asked. "Because I'm a nurse," Sarah said, then immediately regretted how defensive it sounded. "I mean, doctors have more training and education. It's not my place to question their decisions or diagnoses publicly." Doctor set down his fork and leaned forward. "That's exactly the kind of thinking that gets patients killed," he said bluntly. "Medicine isn't about hierarchy or ego. It's about collaboration and using every resource available to help patients. If you see something concerning, you have not just the right but the responsibility to speak up, regardless of who else is in the room." Sarah felt something shift inside her at those words. She had heard similar sentiments before in nursing school and during hospital orientation sessions about patient safety and teamwork. But hearing it from Doctor, who was known for his exacting standards and no-nonsense approach, gave the message a weight it had never had before. "I want to ask you something," Doctor continued. "Have you ever considered becoming a physician assistant or going to medical school?" The question caught Sarah completely off guard. She stared at him for a moment, trying to determine if he was serious. The thought of becoming a doctor had crossed her mind occasionally over the years, usually during quiet moments when she wondered what her career might look like in 5 or 10 years. But she had always dismissed the idea as impractical. Medical school was expensive and time-consuming, and she had student loans from nursing school still to pay off. Besides, she was good at what she did. Why would she give up a career where she felt competent and valued to start over as a medical student? "I've thought about it," Sarah said carefully, "but it's not really realistic for me right now." "Why not?" Doctor asked. Sarah listed her reasons, the same ones she had repeated to herself countless times. The cost, the time commitment, the difficulty of balancing school with work and personal life. Doctor listened without interrupting, his expression thoughtful. "Those are all valid concerns," he said when she finished. "But they're also all obstacles that can be overcome if you're motivated enough. The question is, do you want to be a doctor?" Sarah opened her mouth to give him a polite non-answer, but something made her pause. Did she want to be a doctor? Really, honestly want it? She thought about the satisfaction she felt when she figured out what was wrong with the patient that morning, the thrill of seeing her assessment proven correct, the knowledge that her clinical judgment had made a life-or-death difference. She thought about all the times she had wished she could order tests or treatments herself instead of having to suggest them to a physician. She thought about the patients who had looked to her for answers that she wasn't authorized to give. "I don't know," she said finally, and it was the most honest answer she could give. "I love being a nurse. I'm good at it. But sometimes I wonder what else I could do if I had more training and authority." Doctor nodded as if this was exactly the answer he had expected. "I'm going to tell you something that might sound arrogant," he said. "When I watched you during that resuscitation this morning, I didn't see a nurse doing her job. I saw a clinician making a differential diagnosis and advocating for her patient. That's not a skill you can teach in a classroom. It's instinct combined with experience and knowledge. You have it. The question is what you're going to do with it." Before Sarah could respond, Doctor's pager went off. He glanced at it and stood up quickly. "I have to go," he said. "But think about what I said." "And Sarah," he added as he picked up his tray, "don't sell yourself short. You're capable of more than you realize." He walked away before she could thank him or ask what he meant by that last statement. Sarah sat alone at the table, her sandwich still mostly uneaten, her mind churning with thoughts and possibilities she had tried not to consider for years. The afternoon shift was busy enough to distract Sarah from the conversation with Doctor. She moved through her duties with the same efficiency as always, checking vitals, administering medications, comforting anxious patients and their families. But underneath the surface routine, something was different. She found herself looking at situations with a more analytical eye, thinking through differential diagnoses the way she imagined a physician would, questioning whether the treatment plans made sense based on the symptoms she was observing. Around 3 in the afternoon, an elderly man was brought in complaining of severe abdominal pain. The resident on duty examined him briefly and ordered some routine tests, suspecting it was probably just constipation or a mild infection. But something about the patient bothered Sarah. His pain seemed too severe for something benign, and there was a quality to his voice when he described it that reminded her of other patients she had seen with more serious conditions. She mentioned her concerns to the resident, a young doctor fresh out of medical school who was still learning to trust his clinical judgment. He looked at her skeptically at first, clearly thinking she was overreacting. But to his credit, he didn't dismiss her outright. Instead, he went back to re-examine the patient more thoroughly. 20 minutes later, he came out of the room looking pale and immediately ordered a stat CT scan. The patient had a dissecting abdominal aortic aneurysm, a life-threatening condition that required immediate surgery. Once again, Sarah's clinical instincts had potentially saved a life. Once again, people were looking at her with a mixture of admiration and surprise. The resident thanked her profusely, admitting that he would have missed the diagnosis if she hadn't pushed him to look more carefully. Sarah accepted his thanks graciously, but inside she felt a growing sense of frustration. Why was it surprising that a nurse could recognize serious medical conditions? Why did doctors seem amazed when nurses demonstrated critical thinking skills? Weren't nurses supposed to be partners in patient care, not just task-oriented assistants who followed orders without question? The more Sarah thought about it, the more the limitations of her role began to chafe against her growing confidence in her clinical abilities. When her shift finally ended at 7 that evening, Sarah was exhausted both physically and emotionally. She changed out of her scrubs in the locker room, nodding absently to other nurses who were coming on for the night shift. On her way out of the hospital, she passed by the intensive care unit and made a quick detour to check on the cardiac tamponade patient from that morning. The ICU was quieter than the emergency department, with dimmed lights and the soft beeping of monitors creating an oddly peaceful atmosphere. Sarah found her patient in a room near the nurse's station. He was sitting up in bed, awake and alert, talking quietly with a woman who appeared to be his wife. Sarah paused in the doorway, not wanting to interrupt. The patient noticed her and his face lit up with recognition, despite the fact that he had been barely conscious when she first saw him. "You," he said, his voice still a bit hoarse from the breathing tube. "They told me you're the nurse who figured out what was wrong with me." Sarah stepped into the room, suddenly feeling shy. "I'm Sarah," she said. "I just wanted to check on you and see how you were doing." The patient's wife stood up and rushed over to her, grabbing Sarah's hands in both of hers. The wife's eyes were red from crying but filled with gratitude. "Thank you," she said, her voice breaking. "Thank you for saving my husband. The doctors told us that if you hadn't realized what was wrong, he wouldn't have made it." Sarah felt tears prick at her own eyes. "I'm just glad I was there," she said, "and glad that doctor listened to me." The patient, whose name Sarah learned was Robert, wanted to know exactly what had happened. Sarah explained in simple terms how cardiac tamponade worked, how fluid around the heart had prevented it from beating properly, and how draining that fluid had allowed his heart to function again. She didn't mention the 13 minutes of uncertainty, the moment when she had to decide whether to speak up or stay silent, the fear that she might be wrong. Robert and his wife listened intently, asking questions and trying to understand how something like this could happen so suddenly. Sarah answered as best she could, though she admitted that the cardiologist would be able to give them more detailed information about the underlying cause and what the treatment plan would be going forward. As Sarah prepared to leave, Robert called out to her. "Can I ask you something?" he said. "How did you know? How did you see something that all those doctors missed?" Sarah thought about the question. "I've been doing this for a long time," she said. "You start to develop a sense for when something doesn't fit the pattern. Your symptoms and appearance didn't match what I usually see with a regular heart attack. I just trusted my instincts." "Well, I'm grateful you did," Robert said. "You gave me a second chance at life. I won't waste it." Sarah left the ICU feeling emotionally overwhelmed. The gratitude from Robert and his wife had touched something deep inside her, reminding her why she had become a nurse in the first place. She had wanted to help people, to make a difference in their lives during their most vulnerable moments. And today she had done exactly that in a way that was undeniable and profound. As she walked through the hospital parking lot toward her car, Sarah pulled out her phone and scrolled through her contacts until she found the number for her academic advisor from nursing school. Dr. Maria Santos had been a mentor to Sarah during her undergraduate years, encouraging her to pursue nursing and supporting her through the challenges of school and early career development. They still kept in touch occasionally, though Sarah hadn't called her in months. The phone rang 3 times before Dr. Santos answered. "Sarah," she said warmly, "what a pleasant surprise. How are you?" "I'm good," Sarah said, unlocking her car and sliding into the driver's seat but not starting the engine yet. "I'm actually calling because I wanted to ask your advice about something." She told Dr. Santos about the events of the day, about the patient with cardiac tamponade, and the conversation with doctor and the growing feeling that maybe she was capable of more than she had believed. Dr. Santos listened without interrupting, and Sarah could picture her sitting in her office with that thoughtful expression she always got when a student came to her with a serious question. "So you're thinking about medical school," Dr. Santos said when Sarah finished, after 8 years of being a very successful nurse. "I don't know if I'm really thinking about it seriously," Sarah admitted. "Maybe I just needed someone to talk to about the possibility." Dr. Santos was quiet for a moment. Then she said, "Do you remember what I told you when you were deciding whether to go into nursing?" Sarah thought back to her undergraduate years, to the 18-year-old girl she had been, uncertain about her future and intimidated by the challenges ahead. "You told me that nursing was one of the most important and undervalued professions in healthcare," she said. "You told me that nurses were the backbone of patient care and that good nurses saved more lives than most people realized." "That's right," Dr. Santos said, "and it's all still true. But I also remember telling you that you had the kind of mind that would never stop learning and growing. I remember thinking even then that you might not stay a bedside nurse forever, that you would eventually want to expand your scope of practice." "I love being a nurse," Sarah said quickly, feeling defensive for reasons she couldn't quite articulate. "I know you do," Dr. Santos replied gently, "and no one is saying you have to stop being a nurse. But there are many paths in healthcare, Sarah. Being a physician is just one option. Have you considered becoming a nurse practitioner or a clinical nurse specialist? Both roles would give you more autonomy and authority while still keeping you grounded in nursing practice." Sarah hadn't really thought about those possibilities in detail, though she knew several nurses who had gone on to advanced practice roles. I guess I always thought of those as just nursing with more responsibilities, she said, not fundamentally different from what I do now. But they are different, Dr. Santos said. As a nurse practitioner, you could diagnose conditions, order tests, prescribe medications, manage patient care independently in many settings. It's not the same as being a physician, but it might give you the clinical challenges and authority you're looking for without requiring you to completely start over in medical school. The idea had appeal, Sarah had to admit. She could pursue advanced education while still working, could build on her nursing foundation rather than abandoning it, could achieve greater clinical autonomy without the massive time and financial commitment of medical school. But something about it still felt like a compromise, like settling for less than what she might be capable of. Can I be completely honest with you? Sarah asked. Always, Dr. Santos replied. Part of me wonders if going into nursing instead of medicine in the first place was taking the easier path, Sarah said. I told myself it was because I wanted the hands-on patient care and the holistic approach that nursing emphasizes. But maybe it was also because I was afraid I wasn't smart enough for medical school, or because I didn't want to take on that much debt, or because I wanted to graduate and start working sooner. Dr. Santos sighed on the other end of the line. Sarah, I've known hundreds of students over my career. Some became nurses, some became doctors, some went into other health professions. And I can tell you with absolute certainty that intelligence and capability have very little to do with which path someone chooses. The best nurses I know could have been excellent physicians. The best physicians I know would have been excellent nurses. It's about what kind of work feels meaningful to you, and what kind of role you want to play in patient care. But it's also okay to change your mind, Dr. Santos continued. It's okay to realize that what you wanted at 18 or 22 isn't what you want at 32. People grow. Their goals evolve. The question isn't whether you took the easy path before. The question is, what do you want now today with the knowledge and experience you have? I don't know what I want, Sarah admitted. Today felt amazing, figuring out that diagnosis, saving that patient's life, having doctor treat me like a colleague instead of a subordinate. But I also love the bedside care I provide every day. I love the relationships I build with patients. I love being part of a nursing team. I don't want to give that up. Then don't give it up, Dr. Santos said. At least not right away. Think about this decision. Research your options. Talk to physicians and nurse practitioners and physician assistants about what their work is really like. Shadow them if you can. Get a realistic sense of what each path involves before you commit to anything. And remember that this doesn't have to be decided tonight or even this year. You have time. They talked for a few more minutes before saying goodbye, but Sarah felt calmer after the conversation. Dr. Santos was right. She didn't need to make any life-changing decisions immediately. She could take her time, gather information, really think through what she wanted her future to look like. Sarah finally started her car and drove home through the darkening streets. Her apartment was small but comfortable, a one-bedroom place in an older building about 15 minutes from the hospital. She had lived there since finishing nursing school, and it had become her sanctuary, the place where she could decompress after difficult shifts and recharge before the next one. The next few weeks passed in a blur of normal hospital routine, punctuated by moments of unexpected recognition. Sarah continued her regular shifts in the emergency department, but she found that her perspective on her work had shifted. She was more observant now, more willing to question and speak up when something didn't seem right. Some of the doctors appreciated this newfound assertiveness. Others found it irritating, especially the ones who were used to nurses who simply followed orders without offering input or challenging decisions. Sarah had started attending the weekly emergency department morbidity and mortality conferences, something she had never done before because they were technically optional for nursing staff. These conferences were where the medical team reviewed complicated cases, discussed what went right and what went wrong, and tried to learn from their experiences. Traditionally, they were dominated by physicians, with nurses rarely participating in the discussions. But Doctor had specifically invited Sarah to attend after the cardiac tamponade case, and she had decided to take him up on the offer. At her first conference, Sarah sat in the back of the room feeling awkward and out of place. The physicians discussed a case involving a patient who had died despite aggressive treatment, analyzing whether different interventions might have changed the outcome. Sarah listened carefully, following the medical reasoning even when the terminology got complex. At one point, one of the residents mentioned that the patient's initial presentation had been unusual. but they had attributed it to anxiety rather than a physical cause. Sarah raised her hand hesitantly. When she was called on, she felt her face flush as all eyes in the room turned toward her. "I had a similar patient about 6 months ago," she said. "The symptoms looked like anxiety at first, but something felt off to me. I asked the attending to consider pulmonary embolism even though the patient was young and had no obvious risk factors. Turned out she had a saddle embolus." There was a moment of silence as the physicians processed this. Then Doctor, who was leading the conference, nodded thoughtfully. "That's an excellent point," he said. "Sometimes we let demographics and expectations cloud our clinical judgment. What made you suspicious of PE in that case?" Sarah described the subtle signs she had noticed, things that individually seemed insignificant but together painted a picture of something more serious than simple anxiety. As she spoke, she noticed some of the physicians taking notes, actually taking notes on what a nurse was saying. The realization gave her a confidence boost that carried through the rest of the conference. Afterward, several physicians approached her to discuss cases or ask her opinion on patients currently in the department. It was a strange feeling, being consulted by doctors as if her input mattered just as much as theirs. Some of them seemed genuinely interested in her perspective. Others appeared to be going through the motions, asking out of politeness rather than genuine curiosity. But either way, Sarah felt something shifting in how she was perceived within the department hierarchy. Rachel cornered her in the cafeteria a few days later, her eyes sparkling with curiosity. "So I've been hearing rumors," she said without preamble as she sat down across from Sarah with her tray. "You're going to medical school." Sarah nearly choked on her coffee. "What? No, who told you that?" Rachel laughed. "Hospital gossip, obviously. Someone heard that doctor told you that you should be a doctor, and now people are speculating about whether you're going to leave nursing." Sarah shook her head in exasperation. "I'm not leaving nursing. I just saved one patient's life, and suddenly everyone thinks I'm going to abandon my career." "But you have thought about it," Rachel said, her tone more serious now. "Going to medical school, I mean, or something like that. I can see it in your face." Sarah sighed and set down her coffee cup. She had been friends with Rachel since their first year of nursing school, and Rachel could read her better than almost anyone. "Maybe," she admitted. "I've been researching different options. Medical school, physician assistant programs, nurse practitioner school. I'm not sure what I want to do yet." Rachel leaned back in her chair and studied her friend. "What's holding you back?" "A lot of things," Sarah said. "Money, time, fear of failure. The fact that I actually like my job most of the time. The question of whether wanting more autonomy and authority is a good enough reason to completely change my career path." "Those all sound like excuses," Rachel said bluntly. "What's the real reason?" Sarah thought about that for a long moment. "I guess I'm afraid of losing what I have," she said finally. "Being a nurse gives me direct patient contact, meaningful relationships, a clear role and identity. If I become a doctor or a PA or an NP, I'll be something different. Maybe something better in terms of career advancement and clinical authority, but also something that takes me further away from bedside care." "Why do you assume it has to be one or the other?" Rachel asked. "Can't you have both? Can't you advance your education and still maintain the aspects of nursing that you love?" "I don't know if that's realistic," Sarah said. Rachel reached across the table and grabbed Sarah's hand. "Listen to me," she said firmly. "I have watched you for 8 years be an incredible nurse. You are smart, dedicated, compassionate, and you have this gift for seeing what other people miss. Whatever you decide to do with your career, you're going to be great at it. But you're not going to be happy if you let fear keep you from pursuing what you really want." Sarah felt tears prick at her eyes. "How do I know what I really want?" "You start by being honest with yourself," Rachel said. "Stop thinking about what you should want or what makes the most sense on paper. Think about what would make you excited to get up and come to work every day. Think about what kind of impact you want to have. Then make a decision based on that." The conversation with Rachel stayed with Sarah over the following days. She found herself paying attention to the different healthcare professionals she worked with, observing what their days looked like and how satisfied they seemed with their roles. She watched the physicians juggling multiple responsibilities, constantly being pulled in different directions, making life and death decisions while also dealing with administrative burdens and insurance headaches. She observed the nurse practitioners who worked in the department, noting how they seemed to have a nice balance of autonomy and collaborative practice. She talked to the physician assistants about their training and career paths. Sarah also started shadowing whenever she had the opportunity. On her days off, she would come to the hospital and follow different providers through their shifts, watching how they interacted with patients, how they made decisions, what their workflow looked like. It was eye-opening to see healthcare from perspectives other than her nursing one. One afternoon, she shadowed Dr. Jennifer Wu, a hospitalist who managed patients admitted to the general medicine floors. Dr. Wu was in her late 30s, warm and efficient, with a reputation for being an excellent teacher. As they made rounds together, Dr. Wu explained her thought process for each patient, discussing how she weighted different symptoms and test results to arrive at diagnoses and treatment plans. At one point, they saw a patient who had been admitted for pneumonia but wasn't responding to the antibiotics as expected. Dr. Wu reviewed the chart carefully, then examined the patient again. She seemed puzzled by something, her brow furrowed in concentration. "What do you think?" she asked Sarah. "You're looking at him with your nurse eyes. Do you see anything concerning?" Sarah approached the bedside and did her own assessment. The patient was an older gentleman, probably in his 70s, with thin white hair and pale skin. His breathing was labored despite the oxygen he was receiving. Sarah checked his oxygen saturation, felt his pulse, listened to his lung sounds with her stethoscope. Then she looked at his legs and noticed significant swelling in both ankles and calves. "His fluid status seems off," Sarah said. "He's got pretty significant peripheral edema, and his heart rate is faster than I would expect. Have you considered that this might be heart failure rather than just pneumonia, or maybe both?" Dr. Wu's eyes lit up. "That's exactly what I was thinking," she said. "The chest X-ray showed some infiltrates that were read as pneumonia, but I was wondering if they might actually be pulmonary edema." Good catch. They ordered additional tests and adjusted the patient's treatment plan accordingly. Later, when they had a moment alone, Dr. Wu turned to Sarah with a curious expression. "You think like a physician," she said. "Have you ever considered going to medical school?" Sarah laughed at hearing the same question she had been asked multiple times over the past few weeks. "Actually, yes," she admitted. "I've been thinking about it a lot lately." "What's stopping you?" Dr. Wu asked. Sarah gave her the usual list of concerns. Dr. Wu listened patiently, then shared her own story. She had been a nurse for 5 years before deciding to go to medical school. The transition had been challenging, she admitted, both academically and emotionally. There had been times when she missed nursing, missed the direct patient care and the team environment. But ultimately, she didn't regret her decision. "The thing is," Dr. Wu said, "nursing and medicine are different but complementary. My nursing background made me a better doctor because I understood the whole picture of patient care, not just the diagnostic and prescriptive aspects. I knew what nurses dealt with every day, what patients experienced beyond their interactions with physicians. That perspective has been invaluable." "Did you ever feel like you were betraying nursing by becoming a doctor?" Sarah asked. Dr. Wu considered the question. "Some people saw it that way," she said honestly. "There were nurses who felt like I was abandoning the profession, like I thought nursing wasn't good enough for me. But the way I saw it, I was expanding my ability to help patients. I wasn't saying nursing was inferior. I was just choosing a different path that aligned better with my particular skills and interests." The conversation gave Sarah a lot to think about. She had been so focused on whether she should pursue medicine that she hadn't really considered the why beyond vague notions of wanting more authority and autonomy. But Dr. Wu's perspective made her think more deeply about what specifically drew her to medicine versus what she valued about nursing. That evening, Sarah sat down with a notebook and made 2 lists. On one side, she wrote everything she loved about being a nurse. On the other side, she wrote everything that frustrated her about her current role. Then she made a 3rd list of what she thought she might gain by pursuing advanced education, whether as a physician or in some other capacity. The lists were revealing. What she loved about nursing centered around relationships, both with patients and with colleagues. The ability to spend significant time with patients, to really get to know them as people rather than just cases. The teamwork and camaraderie among nursing staff. The variety of tasks and the hands-on nature of the work. The feeling of being essential to patient care in tangible, immediate ways. What frustrated her was primarily about limitations. Not being able to order tests or treatments she thought patients needed. Having to go through multiple layers of hierarchy to get concerns addressed. Being dismissed or overlooked despite her experience and expertise. Feeling like her critical thinking skills were underutilized because her role was seen as primarily task-oriented rather than intellectual. What she might gain from advancing her education included greater clinical autonomy, the ability to make independent diagnoses and treatment decisions, more respect and authority within the healthcare hierarchy, and potentially higher income and more career options. But she also noted potential losses: the distance from bedside care, less time with individual patients, more administrative and documentation burdens, and the possibility of losing the nursing identity and community she valued. Looking at the lists, Sarah realized that her dilemma wasn't really about nursing versus medicine. It was about finding a role that would allow her to use all of her skills and knowledge while still maintaining the aspects of patient care that brought her the most satisfaction. Maybe that meant becoming a physician. Maybe it meant becoming a nurse practitioner. Or maybe it meant finding ways to expand her current role and continue growing as a bedside nurse. Sarah was still contemplating her lists when her phone rang. It was a number she didn't recognize with a local area code. She answered cautiously. "Is this Sarah Mitchell?" a male voice asked. "Yes, who's calling?" "This is Robert. You saved my life a few weeks ago." Sarah sat up, surprised to hear from her former patient. "Mister, how are you? Are you doing okay?" "I'm doing great, actually," Robert said. "I'm back at work part-time and my cardiologist says my prognosis is excellent. But that's not why I'm calling." "Oh," Sarah said, curious now. "My brother-in-law is on the board of directors at Mary's," Robert continued. "I told him what happened, how you diagnosed my condition when everyone else thought I was having a regular heart attack. He was very impressed. He wants to meet with you." "Meet with me? Why?" Robert chuckled. "Because the hospital is starting a new initiative to recognize and empower exceptional nursing staff. They want nurses who demonstrate advanced clinical skills to have more input in policy decisions, more opportunities for professional development, that sort of thing. Your name came up, not just because of what happened with me, but because apparently you've been making quite an impression in the ED lately." Sarah felt her heart start to race. "I don't know what to say," she managed. "Say you'll take the meeting," Robert urged. "My brother-in-law's name is Thomas Reed. He's going to call you directly to set something up. Just hear what he has to say. You don't have to commit to anything." "Okay," Sarah agreed, still trying to process this unexpected development. "Thank you for thinking of me." "Thank you for saving my life," Robert said simply. "I mean that sincerely. You gave me more time with my family, more time to do the things I love. Whatever happens with your career, I hope you know that you make a real difference." After they hung up, Sarah sat in stunned silence for several minutes. It seemed like the universe was conspiring to push her toward something, though she wasn't entirely sure what that something was. Opportunities were appearing that she hadn't sought out, conversations were happening that challenged her assumptions, and doors were opening that she hadn't even known existed. The next morning, Sarah received a call from Thomas Reed, who introduced himself as a member of the hospital board of directors. He spoke in the measured tones of someone used to wielding authority, but there was also a warmth in his voice that put Sarah somewhat at ease. "We're launching a new clinical excellence program," he explained. "The goal is to identify nurses who demonstrate exceptional clinical judgment and give them more opportunities to influence patient care beyond their direct bedside interactions. This might include serving on committees, participating in protocol development, mentoring newer nurses, that sort of thing." "That sounds interesting," Sarah said cautiously. "What exactly would be involved?" "We're still working out the details," Thomas admitted. "But I'd like to meet with you and a few other nurses we've identified as potential participants to get your input on what would be most valuable. Would you be willing to join us for a planning meeting next week?" Sarah agreed, and they set up a time. After the call ended, she found herself both excited and nervous about this new opportunity. It wasn't medical school or a nurse practitioner program, but it was something, a way to expand her influence and impact without necessarily leaving her current role. She decided to talk to Doctor about it. She found him in the emergency department physician's lounge, reviewing lab results on his computer. He looked up when she knocked on the doorframe and gestured for her to come in. "I wanted to update you on something," Sarah said, then told him about the call from Thomas Reed and the Clinical Excellence Program. Doctor leaned back in his chair and smiled. "I'm not surprised," he said. "Word has been getting around about your clinical skills. You've become something of a legend in certain circles." Sarah felt her cheeks heat up. "I don't know about that." "I do," Doctor said firmly. Sarah, in the past few weeks, you've identified cardiac tamponade, a dissecting aortic aneurysm, and a pulmonary embolism that other clinicians missed. You've been contributing meaningfully to our morbidity and mortality conferences. You've been asking thoughtful questions and challenging assumptions when they don't align with what you're observing. That's not just good nursing. That's exceptional clinical practice. I'm just doing my job, Sarah protested. No, doctor said. You're doing much more than your job. And that's exactly why I think this clinical excellence program could be good for you, and why I also still think you should seriously consider the planning meeting for the clinical excellence program took place in one of the hospital's nicer conference rooms, the kind usually reserved for board meetings and important presentations. Sarah arrived 15 minutes early, her nerves making her feel like she needed extra time to prepare herself even though she wasn't sure what she was preparing for. The room had a long, polished table surrounded by comfortable chairs, large windows overlooking the city, and a coffee station with surprisingly good pastries. Sarah poured herself a cup of coffee and selected a blueberry muffin, then took a seat halfway down the table where she could see everyone without being in the most prominent position. As other participants began arriving, she recognized a few faces. There was Johnson, a veteran ICU nurse who had been with the hospital for over 15 years and had a reputation for catching medication errors before they could harm patients. Lisa, an oncology nurse known for her exceptional skill in managing complex symptom control and supporting patients through difficult treatments. David from the cardiac care unit, who had once talked a patient out of leaving against medical advice by simply listening to their fears and addressing them with patience and compassion. In total, there were 8 nurses invited to the meeting, representing different departments and specialties, but all sharing a common thread of being recognized by their peers and supervisors as exceptional clinicians. Sarah felt both honored and intimidated to be included in this group. Thomas Reed arrived exactly on time, accompanied by 2 other hospital administrators and doctor, who gave Sarah an encouraging nod as he took a seat near the head of the table. Thomas called the meeting to order and began by thanking everyone for coming. Each of you represents the best of what nursing can be, he said. You've been identified by your colleagues and supervisors as nurses who go above and beyond, who demonstrate critical thinking and clinical excellence, who make a measurable difference in patient outcomes. This program is our attempt to recognize that excellence, and more importantly, to leverage it to improve care throughout the hospital. He went on to explain the vision for the program. Selected nurses would serve as clinical consultants, available to be called when complex cases needed additional assessment or when staff members were uncertain about patient care decisions. They would participate in quality improvement initiatives, help develop new protocols and guidelines, and mentor less experienced nurses. They would also receive additional compensation for these expanded responsibilities and would have protected time for these activities built into their schedules. This isn't about creating a hierarchy among nurses, Thomas emphasized. It's about recognizing that some nurses have developed expertise that should be shared more broadly for the benefit of patients. We want to create a culture where clinical excellence is rewarded and where experienced nurses have pathways for professional growth that don't require leaving bedside care. Sarah found herself nodding along as he spoke. This was exactly the kind of opportunity she had been hoping for, a way to expand her impact and use her clinical skills more fully without abandoning the aspects of nursing she loved. But she also had questions. When Thomas opened the floor for discussion, Sarah raised her hand. How will this program interact with the existing medical hierarchy? She asked. Nurses are already expected to collaborate with physicians and follow medical orders. How do we navigate situations where a clinical consultant nurse's assessment might differ from a physician's? It was a delicate question, one that touched on the often fraught relationship between nursing and medical authority. Sarah saw a few of the other nurses exchange glances, clearly wondering the same thing but perhaps not wanting to be the first to ask. Thomas looked at Doctor, who cleared his throat before responding. That's an excellent question, Doctor said, and it gets at one of the fundamental issues we're trying to address with this program. The traditional hierarchical model of healthcare, where physicians make all the decisions and nurses simply carry them out, doesn't serve patients well. We know from research and experience that better outcomes occur when there's true collaboration, and when all team members feel empowered to speak up about concerns. He paused, seeming to choose his words carefully. Clinical consultant nurses won't have the authority to overrule physician orders, he continued. That would create legal and liability issues we can't resolve. But they will have a direct line of communication to attending physicians and department heads. Their assessments and recommendations will carry weight because they're coming from recognized experts. And we're going to work on creating a culture where physicians actively seek out and value nursing input rather than seeing it as a challenge to their authority. Another nurse from the ICU spoke up. What happens when a physician ignores or dismisses a clinical consultant's concerns? We've all been in situations where we knew something was wrong with a patient but couldn't get anyone to listen until it was almost too late. Thomas nodded seriously. That's why we're also implementing a formal escalation process as part of this program. If a clinical consultant raises a concern and feels it's not being adequately addressed, they'll have the ability to escalate to the department chair or even to the chief medical officer if necessary. We're making it clear from the top down that these consultations aren't optional or advisory. They're an integral part of our quality and safety protocols. The discussion continued for over an hour, covering everything from how nurses would be selected for the program to how much time they would dedicate to consultant activities versus their regular duties. Sarah listened more than she spoke, absorbing information and mentally processing how this opportunity might fit into her career trajectory. As the meeting was wrapping up, Lisa from oncology asked a question that struck directly at something Sarah had been wondering about. Is this program meant to be an alternative to nurses pursuing advanced degrees? She asked. Or is it compatible with someone who might also be considering going back to school? Thomas and Doctor exchanged a look. It's definitely compatible, Thomas said. In fact, we hope some of you will pursue additional education. Having clinical consultants with advanced degrees would only strengthen the program. We see this as one piece of a larger effort to create multiple pathways for nursing career advancement. After the meeting ended, several participants lingered to talk among themselves and network. Sarah found herself in conversation with who had been a nurse longer than she had been alive. What do you think? He asked her. Are you going to sign up? I think so, Sarah said. It sounds like an amazing opportunity. But I'm also considering going back to school, maybe for a nurse practitioner degree or even medical school. I'm trying to figure out how everything fits together. Laughed a warm, rumbling sound. You're at that stage in your career where the possibilities feel overwhelming, he said. I remember it well. My advice? Don't try to plan out the next 20 years. Take the next good opportunity that comes along and see where it leads. You can always adjust course later. Did you ever think about going back to school? Sarah asked. Many times, admitted, and I did actually. I got my master's degree in nursing about 10 years ago, but I stayed at the bedside because that's where I felt I could make the most difference. For some people, advancing their career means moving into management or education or research. For me, it meant getting better at direct patient care. There's no one right path. Sarah appreciated his perspective. It was a reminder that career decisions didn't have to be all or nothing, that there were multiple ways to grow and contribute. Over the following weeks, Sarah threw herself into the clinical consultant program while continuing her regular emergency department shifts. She attended training sessions on consultation skills, conflict resolution, and evidence-based practice. She shadowed experienced clinical nurse specialists to learn how they approached complex cases, and she began taking consultation calls, being available to other units when they had questions or concerns about patient care. Her first official consultation came from a surgical floor nurse who was worried about a post-operative patient. The patient had routine gallbladder surgery 2 days earlier and should have been recovering normally, but something felt wrong to the bedside nurse. The patient was complaining of increasing abdominal pain, seemed more confused than before, and had developed a low-grade fever. Sarah reviewed the chart carefully before going to assess the patient in person. The vital signs were concerning but not critical. The lab work showed a slight elevation in white blood cells, but nothing dramatic. The surgeon's notes indicated the procedure had gone smoothly with no complications. On paper, this looked like normal post-operative discomfort, maybe a minor infection that would respond to antibiotics. But when Sarah examined the patient, her instincts told her something different. The patient's abdomen was more distended than it should be 2 days post-op. The pain seemed out of proportion to what she would expect, and there was a subtle change in the patient's mental status that worried her. Sarah spoke with the bedside nurse, asking detailed questions about how the patient had been over the past few hours. The nurse confirmed that there had been a gradual decline, nothing sudden or dramatic, but a slow downward trend that didn't feel right. Based on her assessment, Sarah recommended calling the surgeon for a reevaluation and suggested ordering a CT scan of the abdomen. The resident on duty was initially resistant. The patient just had surgery, he argued. Some discomfort is normal. A CT scan seems excessive. But Sarah stood her ground. She explained her reasoning calmly and professionally, citing specific findings and expressing her concern that there might be a complication like an anastomotic leak or internal bleeding that wasn't obvious yet. The resident still seemed unconvinced, but because Sarah was there as an official clinical consultant, he agreed to call the attending surgeon. The surgeon initially shared the resident's skepticism, but agreed to come evaluate the patient given Sarah's concerns. After his examination and review of the case, he ordered the CT scan. 2 hours later, they had an answer. The patient had developed a bile leak from the surgical site, causing bile to accumulate in the abdomen and leading to peritonitis. It was a serious complication that required immediate surgical intervention. The patient was taken back to the operating room that evening, and the leak was repaired successfully. Because it had been caught relatively early thanks to Sarah's consultation, the patient avoided sepsis and other life-threatening complications. Recovery would be longer than initially expected, but the prognosis was good. The bedside nurse who had called for the consultation sought Sarah out the next day to thank her. "I knew something was wrong," she said, "but I didn't trust my instincts enough to really push for it. Seeing you advocate for the patient gave me confidence that I wasn't just being paranoid." That interaction made Sarah realize something important. Her role as a clinical consultant wasn't just about catching problems that others missed. It was also about validating and supporting other nurses, helping them trust their own clinical judgment and feel empowered to speak up. She was modeling the kind of assertive, confident nursing practice that she herself had struggled to develop over the years. As Sarah's reputation grew within the hospital, she found herself increasingly pulled in different directions. The clinical consultant role was taking up more of her time, even though she was still working regular shifts in the emergency department. She was asked to join several committees, to present at nursing education sessions, to mentor new graduate nurses. It was flattering and exciting, but it was also exhausting. She talked about it with Rachel over dinner one evening at their favorite Thai restaurant. "I feel like I'm being stretched too thin," Sarah admitted as she picked at her pad thai. "Everyone wants a piece of my time, and I'm trying to say yes to everything because these are all good opportunities. But I'm burning out." "You need to learn to say no," Rachel said bluntly. "You can't do everything, and trying to will just make you miserable and less effective at the things you do choose to do." "But how do I decide what to say no to?" Sarah asked. "How do I know which opportunities are worth pursuing and which ones I should pass up?" Rachel set down her fork and looked at her friend seriously. "You go back to that question we talked about before. What do you actually want? Not what sounds impressive or what other people think you should do, but what genuinely excites you and aligns with your goals." Sarah thought about that. The clinical consultant work excited her because it allowed her to use her diagnostic skills and make a broader impact. The committee work was interesting, but often felt bureaucratic and slow. The mentoring was rewarding but time-consuming. The regular ED shifts were familiar and comfortable but increasingly felt limiting given her expanding capabilities. "I think I want to focus on the direct clinical work," Sarah said slowly. "The consultations, the complex case management, the problem-solving, the administrative and committee stuff is fine, but it's not what energizes me." "Then there's your answer," Rachel said. "Say yes to opportunities that involve direct patient care and clinical decision-making. Politely decline or limit your involvement in things that are primarily administrative or bureaucratic, and use the time you free up to really excel at the work you care about." It sounded simple when Rachel said it, but Sarah knew it would be challenging to actually implement. Saying no didn't come naturally to her. She was a people pleaser, someone who hated disappointing others or seeming ungrateful for opportunities. But she also recognized that Rachel was right. She needed to be more strategic about how she spent her time and energy. Around this same time, Sarah received an unexpected invitation. The State Nursing Association was hosting their annual conference, and they wanted her to present a session on advanced clinical assessment skills for bedside nurses. It was both an honor and a significant commitment. Preparing a presentation would take considerable time, and the conference was only 6 weeks away. Sarah's first instinct was to panic and maybe decline, worried that she wasn't qualified to teach other nurses or that she wouldn't have time to prepare properly. But then she remembered her conversation with Rachel about focusing on what excited her, teaching other nurses how to develop their clinical judgment and trust their instincts. That was exactly the kind of work that aligned with her values and goals. She accepted the invitation and threw herself into preparing the presentation. She reached out to some of the nurses she had worked with over the years, asking them to share stories of times when their clinical instincts had led to important discoveries or prevented adverse outcomes. She reviewed research on nursing expertise and clinical reasoning. She developed case studies that would challenge participants to think critically and recognize subtle patterns. As she worked on the presentation, Sarah found herself reflecting deeply on her own journey as a nurse. She thought about that scared new graduate who had doubted herself constantly, who had been afraid to speak up even when she noticed something concerning. She thought about the gradual accumulation of experience and knowledge that had built her confidence. She thought about the key moments that had challenged her to step outside her comfort zone, like that morning when she interrupted a resuscitation to suggest an alternative diagnosis. The presentation came together beautifully. Sarah created an interactive session that combined didactic teaching with case-based discussion and practical tips for developing clinical intuition. She emphasized the importance of pattern recognition, of trusting your instincts while also backing them up with evidence, of having the courage to speak up even when it meant challenging someone with more authority. The week before the conference, Sarah did a practice run-through with a small group of colleagues from Mary's. Their feedback was overwhelmingly positive, but they also challenged her on some points and suggested additional examples that would make the content more applicable to different practice settings. Sarah incorporated their suggestions, grateful for the collaborative input. The nursing conference was held at a large convention center downtown. Sarah arrived early on the day of her presentation, feeling a mixture of excitement and nervousness that reminded her of taking her nursing boards years ago. She checked in at the registration desk, received her speaker badge, and made her way to the assigned conference room. The room was set up theater-style with rows of chairs facing a podium and a large screen for her slides. Sarah tested the audiovisual equipment, making sure her presentation loaded correctly and that the microphone worked. Then she stood at the podium and looked out at the empty seats, imagining them filled with nurses who had taken time out of their busy lives to attend this conference and hopefully learn something from her presentation. As the session time approached, nurses began filing into the room. Sarah watched with growing amazement as more and more people arrived, filling not just the main seating area but the overflow chairs along the walls. By the time she was introduced, there were well over 100 people in the room, some even standing in the back because all the seats were taken. Sarah took a deep breath and stepped up to the podium. "Good morning, everyone," she began, her voice steady despite the butterflies in her stomach. "My name is Sarah Mitchell, and I'm an emergency department nurse at Mary's Hospital. 8 weeks ago, I was just another bedside nurse doing my job. Then 13 minutes changed everything." She launched into her presentation, starting with the story of the cardiac tamponade patient. She didn't sugarcoat the fear she had felt when deciding whether to speak up, the doubt that had plagued her even as she voiced her concern, the relief when her assessment proved correct. She was honest about her journey. Presentation exceeded even Sarah's hopeful expectations. The nurses in the audience were engaged and interactive, sharing their own experiences during the case study discussions, and asking thoughtful questions that pushed Sarah to think more deeply about clinical reasoning and professional development. Several attendees stayed after the session ended to talk with her personally, sharing stories of times they had noticed something important but hadn't felt confident enough to act on it. One older nurse, probably in her late 50s, approached Sarah with tears in her eyes. "20 years ago, I had a patient I knew was deteriorating," she said quietly. "I told the doctor I was concerned, but he brushed me off. The patient coded 6 hours later and didn't survive. I've carried that guilt with me ever since, wondering if I should have pushed harder, should have escalated my concerns instead of just accepting the doctor's dismissal. Your presentation reminded me that nurses have not just the right, but the duty to advocate forcefully for our patients." Sarah felt her own eyes well up as she reached out to squeeze the woman's hand. "I'm so sorry you went through that," she said. but thank you for sharing it with me. Stories like yours are exactly why this conversation is so important. We have to create a culture where nurses feel empowered to trust their instincts and speak up, where our concerns are taken seriously regardless of our position in the hierarchy. After the conference, Sarah returned to Mary's with a renewed sense of purpose. The positive response to her presentation had reinforced her belief that she was on the right path, that focusing on clinical excellence and supporting other nurses to develop their skills was meaningful work that aligned with her values. But she also felt more certain than ever that she wanted to expand her education and scope of practice. She made an appointment with the hospital's education coordinator to discuss her options for pursuing a nurse practitioner degree. The coordinator, a cheerful woman named, pulled up information about several programs, both traditional on-campus options and online programs designed for working nurses. Have you thought about what specialty you'd want to focus on? Asked. Emergency, critical care, family practice, acute care. The options are pretty broad for NPs. Sarah considered the question. She had assumed she would pursue emergency or critical care given her background, but now she wasn't entirely sure. What appealed to her most about being a nurse practitioner was the increased autonomy and ability to make diagnoses and treatment decisions. But she also valued the variety and fast-paced environment of the emergency department. Maybe emergency, she said, or acute care. I like the complexity and unpredictability of emergency medicine, but I also appreciate having time to really think through a case rather than just stabilizing someone and sending them elsewhere. Nodded and made some notes. Those are both excellent choices given your experience and interests. Let me pull up some programs that offer those specialties. We can also look at the admission requirements and start planning a timeline for applications. Over the next hour, they mapped out what Sarah's path to becoming a nurse practitioner might look like. Most programs required the GRE or a similar entrance exam. She would need letters of recommendation from supervisors and colleagues. She would need to write a personal statement explaining why she wanted to pursue advanced practice. And she would need to figure out how to balance school with continuing to work, at least part-time, because she couldn't afford to go 2 or 3 years without income. It was daunting when she looked at everything laid out like that, but it also felt manageable. Unlike medical school, which would require her to essentially start over and commit to years of full-time education and training, a nurse practitioner program built on her existing knowledge and experience. She could complete it in 2 to 3 years while still working, and the cost, while significant, was less overwhelming than medical school tuition. Sarah left the meeting with a folder full of program information and a tentative timeline. She would spend the next few months researching programs more thoroughly and preparing her application materials. She would take the GRE in about 6 months. If everything went according to plan, she could start a program within a year and graduate as a nurse practitioner in 3 years, when she would be 35 years old. That evening, Sarah called her parents to tell them about her decision. Her mother answered on the second ring, and Sarah could hear the television in the background. "Hi, honey," her mother said warmly. "How are you? Your father and I were just watching a show about Alaska. Did you know that bears can run 30 miles per hour?" Sarah laughed. "No, I didn't know that. Mom, can you turn down the TV for a minute? I want to tell you something." She heard the sound decrease and her father's voice in the background asking what was going on. Her mother told him it was Sarah, and then her father picked up the extension phone in their bedroom. "What's up, Pumpkin?" her father asked, using the nickname he had called her since she was a little girl. Sarah took a deep breath. "I've decided to go back to school to become a nurse practitioner," she said. "I wanted to tell you both before I started the application process." There was a moment of silence, and then her mother squealed with delight. "Oh, Sarah, that's wonderful. I'm so proud of you." Her father was more measured in his response, which was typical for him. "That's a big decision," he said. "What made you decide to do this now?" Sarah told them about the cardiac tamponade case, about the clinical consultant program, about her presentation at the nursing conference, about the growing realization that she wanted more autonomy and responsibility in her clinical practice. Her parents listened without interrupting, and she could picture them sitting in their comfortable suburban home, her mother probably perched on the edge of the bed with excitement, and her father leaning back against the headboard processing everything analytically. When she finished, her father asked practical questions about the cost and time commitment and how she would manage working while in school. Her mother asked whether this meant Sarah might eventually move to a different hospital or city for better opportunities. They both expressed support for her decision while also making sure she had thought through the implications and challenges. Before they hung up, her mother said something that stuck with Sarah. "You know, honey, when you first told us you wanted to be a nurse instead of going to medical school, your father and I were a little disappointed. Not because nursing isn't a noble profession, but because we knew how smart you were and we wanted you to reach your full potential. But watching you develop over these past 8 years, seeing you find your passion and excel at what you do, I realized that you made exactly the right choice. You needed to be a nurse first to become the kind of advanced practitioner you're going to be." Sarah felt tears prick at her eyes. "Thanks, Mom," she said quietly. "That means a lot." Over the following months, Sarah threw herself into the application process while continuing her work as a clinical consultant and emergency department nurse. She studied for the GRE, carving out time early in the mornings before work to review math concepts she hadn't used since college and practice the verbal reasoning sections. She reached out to Dr., the nurse manager of the emergency department, and from the Clinical Excellence Program to ask for letters of recommendation. She drafted and redrafted her personal statement, trying to articulate clearly why she wanted to pursue this path and what she hoped to accomplish as a nurse practitioner. Writing the personal statement was harder than Sarah expected. She kept starting with dry, formal language about advancing her clinical skills and expanding her scope of practice. But every draft felt lifeless and generic, like it could have been written by anyone. Finally, Rachel read one of her drafts and told her bluntly that it was boring. "Write it like you're talking to me," Rachel suggested. "Tell the story of why this matters to you personally, not just professionally. What do you care about? What difference do you want to make? Let that passion come through." Sarah started over, this time beginning with the cardiac tamponade patient and the 13 minutes that had changed her perspective on what she was capable of achieving. She wrote about the patients she had helped, the nurses she had mentored, the growing realization that she had more to offer if only she had the training and authority to do so. She wrote about wanting to be a bridge between nursing and medicine, bringing the holistic, patient-centered approach of nursing together with the diagnostic and prescriptive capabilities of medical practice. She wrote honestly about her doubts and fears alongside her excitement and determination. When Rachel read this version, she smiled and said, "There you go. That's the real you. That's what admissions committees need to see." Sarah submitted applications to 3 different nurse practitioner programs, each with slightly different strengths and approaches, but all offering either emergency or acute care specializations. Then she waited, trying not to obsess over her email inbox for acceptance letters while continuing to focus on her current work. The clinical consultant role continued to evolve and expand. Sarah found herself being called not just for complex medical cases, but also for situations involving difficult family dynamics, ethical dilemmas, or staff conflicts that needed a neutral party with clinical expertise to help navigate. She discovered that she had a gift for de-escalating tense situations and helping people find common ground, skills that complemented her clinical assessment abilities. One particularly challenging consultation involved a young woman with terminal cancer who wanted to leave the hospital against medical advice to spend her remaining time at home. The oncology team was reluctant to discharge her because they felt she needed continued medical support. The patient's family was divided, with some members supporting her wishes and others insisting she stay where she could receive professional care. The patient herself was adamant but also frightened, caught between her desire for autonomy and her fear of dying alone without medical help. Sarah spent over an hour with the patient and her family, listening to everyone's concerns without judgment and helping them articulate what was most important to them. She asked the patient what specifically she was hoping to experience at home that she couldn't have in the hospital. She asked the family members what they were most afraid of happening if she went home. She asked the medical team what their biggest concerns were from a clinical standpoint. Through this conversation, they were able to develop a compromise plan. The patient would be discharged home with hospice care, which would provide medical support and symptom management in her own environment. The family would receive training on how to handle emergencies and comfort care. The oncology team would be available for consultation if needed. It wasn't perfect, and everyone had to give up something they wanted, but it honored the patient's wishes while also addressing the legitimate concerns of her family and medical team. The patient died at home 3 weeks later, surrounded by family and at peace. Her daughter sent a thank you card to Sarah, expressing gratitude for helping them navigate such a difficult decision and ensuring her mother's final days were spent the way she wanted. Reading that card, Sarah felt a profound sense of satisfaction that went beyond the adrenaline rush of making a difficult diagnosis or the pride of mastering a technical skill. She had helped people during one of the hardest experiences of their lives, had brought clarity and compassion to an impossible situation. These kinds of consultations reminded Sarah why she had become a nurse in the first place and reinforced her decision to pursue becoming a nurse practitioner rather than a physician. She didn't want to lose the nursing perspective that valued holistic care, emotional support, and patient autonomy alongside clinical expertise. She wanted to integrate these approaches, not choose between them. In early spring, Sarah received her first acceptance letter from a highly regarded nurse practitioner program about 2 hours away from where she lived. The program offered both online and in-person components, allowing her to continue working while completing her degree. Sarah read the acceptance letter 3 times, hardly believing it was real. She had done it. She had taken the first concrete step toward expanding her career in the way she had been imagining for months. She immediately called Rachel, who screamed so loudly that Sarah had to hold the phone away from her ear. Then she called her parents, who were thrilled but also immediately started asking practical questions about how she would manage the commute and the coursework. Finally, she sent a text to Doctor simply saying, "I got in," knowing he would understand what she meant. His response came back within minutes. "Congratulations. You're going to be an excellent NP. The emergency department will be lucky to have you when you finish." Sarah felt overwhelmed with gratitude for all the people who had supported and encouraged her on this journey. From Rachel's unwavering friendship to Doctor's mentorship to her parents' love and faith in her abilities, she had been blessed with people who believed in her potential even when she struggled to believe in it herself. The next few months were a whirlwind of preparation. Sarah had to figure out her work schedule for the coming academic year, balancing her clinical consultant responsibilities with emergency department shifts and school commitments. She had to arrange housing for the weeks when she needed to be on campus for intensive in-person sessions. She had to mentally prepare herself for being a student again after 8 years of being a confident working professional. On her last shift before starting the program, several of her colleagues threw her a small party in the emergency department break room. There was a sheet cake decorated with a stethoscope and the words "Future NP Sarah" written in blue icing. People gave speeches about working with her, sharing funny stories and touching moments that Sarah had sometimes forgotten, but that had clearly meant something to them. Doctor presented her with a gift from the medical staff, a high-quality diagnostic set including a stethoscope, otoscope, and ophthalmoscope. "These are the tools of advanced practice," he said. "Use them well and remember that the most important tool you have is the one between your ears." The nursing staff gave her a collection of cards, each one containing messages of support and encouragement. Sarah read through them that night at home, crying as she absorbed the kind words and heartfelt wishes from people she had worked alongside for years. They believed in her. They were proud of her. They expected great things from her. Starting the nurse practitioner program was both exhilarating and terrifying. Sarah found herself in classes with nurses from all different backgrounds and experience levels. Some were fresh out of their undergraduate programs with just a few years of experience. Others were seasoned nurses like herself who had spent a decade or more at the bedside before deciding to advance their education. The diversity of perspectives enriched the learning environment, but also highlighted how much Sarah still had to learn. The coursework was rigorous and demanding. Pharmacology pushed her to memorize drug classes, mechanisms of action, side effects, and interactions. Pathophysiology deepened her understanding of disease processes at a level she had never studied before. Advanced health assessment taught her to perform comprehensive physical exams and develop differential diagnoses systematically. She spent hours studying, more hours than she had ever spent in nursing school because the material was more complex and the expectations were higher. But Sarah loved it. Every new concept she mastered felt like adding another tool to her clinical toolbox. Every skill she developed brought her closer to the autonomous practice she had been craving. When she learned to interpret chest X-rays and EKGs, she thought about all the times she had looked at these diagnostic images and wished she could read them herself rather than waiting for a radiologist or physician interpretation. when she practiced performing cardiac and lung examinations. She thought about how this advanced assessment would allow her to catch subtle findings that might indicate serious problems. The program also challenged Sarah to think differently about patient care. As a nurse, she had been trained to implement care plans developed by physicians. As a nurse practitioner, she would be responsible for creating those care plans herself, making independent decisions about diagnosis and treatment. It required a shift in mindset from collaborative implementation to independent clinical reasoning, and Sarah found that shift both empowering and daunting. Her clinical rotations during the program were eye-opening. She spent time in various settings: family practice clinics, urgent care centers, hospital inpatient units, emergency departments, learning how nurse practitioners functioned in different environments. She observed experienced NPs interviewing patients, examining them systematically, ordering appropriate tests, interpreting results, and developing treatment plans. She saw how they balanced efficiency with thoroughness, how they communicated with patients and families, how they collaborated with physicians when needed while still maintaining their independent scope of practice. One of her preceptors, a nurse practitioner named James who worked in a busy urgent care center, gave Sarah advice that stuck with her. "As an NP, you're going to be in this weird middle space," he said. "Not quite a physician, but more than a bedside nurse. Some people won't understand your role or will question your authority. You'll have to be confident in your training and capabilities while also being humble enough to know your limitations and ask for help when you need it." That balance is what makes good nurse practitioners great. Sarah took that advice to heart. She practiced being assertive about her assessments and recommendations while also acknowledging when a case was beyond her current knowledge or experience. She learned to say, "I need to consult with a physician on this," without feeling like she was admitting weakness or incompetence. Knowing your limits was just as important as knowing your capabilities, maybe more so when you were in a position to make decisions that could significantly impact someone's health. The 2 years of the program passed faster than Sarah expected. Between coursework, clinical rotations, and continuing to work part-time at Mary's, she barely had time to breathe. She gave up her clinical consultant role temporarily, unable to juggle it alongside school commitments. She saw less of Rachel and her other friends. She put her social life on hold almost entirely. But she never seriously considered quitting, even during the most stressful moments when she was surviving on too little sleep and too much coffee. Throughout the program, Sarah stayed in touch with Robert, the cardiac tamponade patient whose case had set all of this in motion. They emailed occasionally, and Robert always wanted to know how school was going and what Sarah was learning. He told her repeatedly that he felt personally invested in her success, that knowing she was using the second chance he got to become even better equipped to help other patients gave meaning to his own survival. In the final semester of the program, Sarah had to complete a capstone project that demonstrated integration of everything she had learned. She chose to develop a protocol for emergency department nurses to identify and escalate concerning findings that might indicate time-sensitive diagnoses like cardiac tamponade, aortic dissection, or pulmonary embolism. She based it on her own experiences and on the growing body of research about nursing clinical judgment and early warning systems. Her capstone presentation to the faculty was well received, and several professors encouraged her to consider publishing it in a nursing journal. The idea that her work might contribute to the broader nursing literature, might help nurses in other hospitals develop their clinical assessment skills, was both humbling and exciting. Graduation day arrived in May, 2 years and 1 month after Sarah had received her acceptance letter. She put on the green academic regalia that signified her achievement and joined her fellow graduates in a ceremony that celebrated their completion of rigorous advanced practice education. Her parents were there, beaming with pride. Rachel was there, clutching a bouquet of flowers and a congratulations balloon. Several colleagues from Mary's showed up to support her, including Dr. and from the Clinical Excellence Program. When Sarah walked across the stage to receive her diploma and be hooded as a new nurse practitioner, she thought about the journey that had brought her to this moment. She thought about the frightened new graduate nurse who had started working in the emergency department 8 years ago. She thought about the years of building experience and confidence. She thought about 13 minutes in a trauma bay when everything changed. She thought about all the patients she had helped, all the nurses she had mentored, all the lessons she had learned about clinical practice and professional courage. But most of all, she thought about what came next. This wasn't an ending. It was a beginning. As a nurse practitioner, she would have opportunities to impact patient care in ways she had only imagined before. She would be able to diagnose conditions, prescribe treatments, manage complex cases with greater autonomy. But she would do it with the foundation of nursing care, the holistic perspective and patient advocacy that had always been at the heart of why she did this work. The morning after graduation, Sarah went to Mary's hospital to meet with the emergency department leadership about her new role. They had created a position specifically for her as an emergency nurse practitioner, recognizing her expertise and commitment to the department. She would work alongside the physicians, seeing patients independently but with collaborative oversight, bridging the gap between nursing and medicine in practical daily practice. As she walked through those familiar hallways in her new capacity, Sarah felt the weight of responsibility settle on her shoulders alongside the thrill of possibility. She was no longer just a nurse, though she would always identify as a nurse at her core. She was now an advanced practice provider with the training and authority to make independent clinical decisions that could save lives or, if she got them wrong, potentially harm patients. The first patient Sarah saw as a nurse practitioner was a middle-aged woman complaining of chest pain. Sarah took a thorough history, performed a comprehensive physical exam, ordered appropriate cardiac tests, and carefully reviewed the results. The EKG showed subtle changes that could have been normal variants or could have indicated early cardiac ischemia. Sarah felt her pulse quicken as she considered the differential diagnosis. This was it, the moment where she had to trust her training and make a call. She consulted with the attending physician, presenting her findings and her recommendation that the patient be admitted for further cardiac evaluation despite the ambiguous test results. The physician reviewed her assessment and nodded in agreement. "Your clinical reasoning is sound," he said. "Good catch on those EKG changes. I probably would have sent her home if you hadn't flagged them as concerning." Later that day, the patient's cardiac enzymes came back elevated, confirming that she was indeed having a heart attack despite the relatively mild symptoms and unclear initial tests. Because Sarah had advocated for admission and monitoring, the patient received timely treatment that likely prevented significant heart damage. As Sarah documented the case, she thought about how far she had come from that day 2 years ago when everyone thought she was just a nurse. She had never been just a nurse. None of them were. Every nurse brought skills, knowledge, compassion, and clinical judgment to patient care. What had changed wasn't who Sarah was fundamentally, but rather how she was able to express and utilize those qualities. That evening, Sarah sat in her apartment reflecting on the day. She thought about the woman with chest pain who would recover because someone noticed the subtle warning signs. She thought about all the future patients she would care for in her new role. She thought about the nurses she would continue to mentor and support. She thought about the ongoing evolution of healthcare and the vital role that nurses in all their various forms played in delivering excellent patient care. Sarah's phone buzzed with a text from Rachel wanting to know how her first day as an NP had gone. Sarah smiled and typed out a response. "I diagnosed my first patient today, saved another life, feels different, but also exactly the same, if that makes sense." Rachel's reply came back immediately. "Perfect sense, Yure. Still you, just with more letters after your name, proud of you." Sarah set down her phone and looked around her small apartment. Tomorrow she would go back to Mary's and see more patients. She would continue learning and growing because that process never really ended regardless of how many degrees you earned. She would make mistakes and have victories. She would face challenges and overcome them or learn from failing to do so. She would be part of a healthcare team working together to help people during their most vulnerable moments. They had thought she was just a nurse, as if nurse was a limitation rather than a foundation. But Sarah knew better now. Being a nurse had taught her to observe carefully, to think critically, to advocate fearlessly, to care deeply. Those lessons would serve her throughout her career regardless of what title she held or what role she played. Because at the end of the day, it wasn't about being a nurse or a doctor or a nurse practitioner. It was about being a healer, a helper, someone who made a difference in the lives of others. And that was something Sarah had been from the very beginning. Long before those 13 minutes changed everything, the time she had stayed silent when she should have spoken up. The gradual process of building confidence and clinical expertise, seeing your education. That evening, instead of mindlessly watching television or scrolling through social media like she usually did, Sarah opened her laptop and began researching her options. To everyone who witnessed what happened, that experience and careful observation could be just as valuable as medical degrees and titles.